acting as a hindrance to the surgical approaches to the esophagus. Here is a specimen of the brain, a horizontal section, and this being the lower part of the horizontal section. On the right side, in the frontal area is seen an ulceration, a depression with a capsule around it, and the neighboring brain tissue is normal. This is a specimen of a frontal lobe abscess. However, the differential diagnosis over here would be, it could be an amoebic abscess, hydrated cyst, cysticercosis, or a tuberculoma. It appears to be a chronic abscess, as you can clearly see the outlining. You can clearly see the capsule on the outline of the abscess. A frontal sinus or a frontal lobe abscess presents with signs of raised intracranial tension, as it acts like any other space occupying lesion in the brain. The symptoms being headache, vomiting, or blurring of vision. The frontal sinus involvement leads to behavioral changes for the patient. In ENT, the sites which we are dealing with, a frontal sinus abscess can form from the frontal sinus, from any rhinogenic infection, or from the danger area of the face. These being the sites, and the modes of spread is via osteothrombophlebitis. Here the vessels carry the infection through the peripheral media and adventitia tissues into the brain. The other modes of spread are via bone erosion, meaning direct spread of infection via dissolution of the bone, usually caused in frontal sinusitis as pressure atrophy of the inner lining of the diploic bone of the skull. And the third method of spread of infection intracranially can occur through preformed pathways. By preformed pathways we mean the various openings into the skull through which nerves, vessels are passing. So these openings, along with openings caused by the suture lines, previous signs of trauma or surgery, form a pathway whereby infection can travel intracranially. On getting any one of the symptoms as described before, the patient is clinically examined, having any focus of infection and signs of raised ICT, we advise a CT scan. CT scan is the diagnostic investigation for any intracranial abscess, as it gives us the exact site of abscess as well as the extent. After the CT scan is done, the patient is immediately taken up for a burr hole where the abscess is drained. On the clearance of this abscess, the site of infection which is causing the abscess is then treated. So this is a specimen of the brain having an abscess on the right frontal lobe. So right frontal lobe abscess, and obviously it's a post-mortem specimen. A polyp is edematous prolapsed respiratory mucosa. In case of an antrochoanal polyp, the polyp basically arises from the maxillary sinus. After the edema involves whole of the maxillary sinus, this polyp escapes out into the nasal cavity from the opening of the middle meatus. Antrochoanal polyps are seen in young adults, commonly in the second decade of life. The predisposing factors is infection and sometimes allergy. As far as the sex predilection is, it's found equally in males and females. However, there are many diseases in ENT that you find commoner in females, being atrophic rhinitis, autosclerosis, goiters, postcricoid tumors, glomus jugular tumors, and needless to mention, vocal nodules. The antrochoanal polyp, after having filling the maxillary antrum, enters into the nasal cavity and forms the choanal part. The choanal part is the largest part of the antrochoanal polyp, for the simple reason that the opening of the maxillary sinus is directed backwards and posteriorly. The flow of the cilia is also directed backwards. Inspiration, being stronger than expiration, caused the polyp to fill up the nasopharynx or the choana, and the slope of the nasal floor is also backwards downwards, and this leads to the antrogonal polyp having a very large choanal part. The third part of the antroconal polyp, which is the nasal part, is the smallest of all. The tip of the nasal part is usually blackish in color. This is because of the drying effect, because it is exposed to the external environment. There is metaplasia of the epithelium and therefore the blackening. The normal covering of antroconal polyp is the same nasal mucosal covering, which is pseudo-stratified columnar epithelium. The treatment for an antroconal polyp is Caldwell-Luck, because as you know, the antroconal polyp arises from the maxillary sinus, and as the source is in the maxillary sinus, only a polypectomy would lead to just recurrence of the polyp. However, in children less than 12 years of age, the procedure of Caldwell-Luck cannot be done, and a polypectomy is done for temporary relief from headache, nasal block and nasal discharge. The prognosis of an antroconal polyp is very good because it never ever undergoes any malignant change. Instruments in ENT. For examination of the ear, nose and throat, we use a head mirror which has a concave mirror fitted onto a headband worn by the examiner. This mirror has a central diameter of 2 centimeters. The outer diameter consists of 9 centimeters and a focal length of 23.6 centimeters. This is worn by the examiner on his head. The advantage of using this instrument is that both the hands of the examiner are free for procedures like antral puncture, syringing the ear, doing an indirect laryngoscopy or a posterior rhinoscopy. Binocular vision is preserved by having an aperture in the center of this mirror so that the parallel gaze of the examiner is maintained. And thirdly, the concave mirror concentrates the light onto the patient, and therefore visualization is better because of the illumination. However, recent advances have taken place in ENT. The mirror still persists for use because of the following advantages that we have listed. The next instrument is a ear speculum. This is also known as an oral speculum, used for examination of the external auditory canal, the tympanic membrane. In children, the tympanic membrane is visualized by pulling the pinna downwards and backwards, while in adults the pinna is to be pulled upwards and backwards because of the difference in the alignment of the cartilaginous and bony part of the external auditory canal. For removal of wax, removal of fungus, the oral speculum can be used. The oral speculum is also used during surgical procedures where an endomeatal incision is made, for example like a stapedectomy or a tympanic neurectomy. However, in those cases we use a black colored speculum which does not reflect the light of the microscope. For examination of the nose in ENT, the nasal examination is done with an instrument which is called the Thudicum's nasal speculum, held in the left hand with the middle finger and ring finger on either side. The instrument is gradually closed, and as we open the instrument we can visualize the floor of the nose, the nasal septum, the inferior turbinate, the middle turbinate. This instrument is also used in the operation theatre for various nasal surgical procedures. We have two other types of nasal speculum which are known as St. Clair's nasal speculum, exactly like this but having longer blades,